Hello, welcome to today's Pulmonary Fibrosis Disease Education webinar series. My name is Dave Lederer. I'm a pulmonologist at Columbia University Medical Center in New York, and I'm joined today by Dr. Mridu Gulati, who's an associate professor at Yale School of Medicine in the section of Pulmonary, Critical Care, and Sleep Medicine, who's a renowned expert in interstitial lung disease and occupational illnesses. Welcome, Mridu.
Thank you, and I wanted to thank both Dave and the Pulmonary Fibrosis Foundation for allowing me to speak today. This is obviously a very important topic. And before I begin, I want to say to those of you who have the form of idiopathic pulmonary fibrosis where a cause has not been identified, it's really only natural to wonder, particularly as we talk about diseases that the medical community has established that there is a cause for, why the cause for your lung disease has not been found yet. The webinar, what I'll be talking about today, will cover a few specific forms of pulmonary fibrosis that have known causes, and then emphasize some of the challenges that the medical community faces when trying to prove that exposures can cause disease. These are my disclosures. So, in terms of a brief overview, I'll be speaking about where exposures stand in the interstitial lung disease universe, give examples of fibrotic interstitial lung diseases that are associated with known exposures. I'll be speaking namely about pneumoconioses such as asbestosis and coal workers' pneumoconioses, diseases that are probably familiar to you, chronic hypersensitivity pneumonitis that has received a lot of attention in the most recent years, and talk very briefly about idiopathic pulmonary fibrosis and exposures. And is there any evidence that exposures may be related or associated with idiopathic pulmonary fibrosis? So first, I'd like to start by defining terms, and I think this still continues to be a problem, all the alphabet soup of terms that we use for our patients. So I'll start simply by saying that pulmonary fibrosis is not just one disease. It's a family of more than 200 diseases. And pulmonary fibrosis itself falls into an even larger group of diseases called interstitial lung diseases. And when there's scar in the lung tissue in this interstitial lung disease, we call it pulmonary fibrosis. So in looking at the world of exposures in the interstitial lung disease world, we divide, and I'll be using interstitial lung disease and pulmonary fibrosis at times that may be used interchangeably. But we think about forms of pulmonary fibrosis that have known causes or associations. And then we think about forms of pulmonary fibrosis that have unknown associations. And within the forms that have known associations, we think about things like connective tissue diseases such as rheumatologic diseases, rheumatoid arthritis, people who have familial or genetic predispositions to disease. And then in this orange box that you can see there, we think about exposures that are related to interstitial lung disease. And on the other side, we look at interstitial lung diseases of unknown associations, and there we have the form that we hear frequently about, idiopathic pulmonary fibrosis. And of course, we wonder, is that really truly idiopathic means unknown cause? Is it really truly unknown? So what are the challenges to prove for scientists and medical community members how to prove that exposures actually cause fibrotic lung disease? Well, there's several challenges. First of all, the disease and symptoms don't occur until many, many years after exposure. That means that while somebody's working with a particular material, they may not have symptoms at all. People also don't remember what they were exposed to. We're now examining and taking a patient history 20, 30 years later, maybe after the disease is present. And then, of course, people may be biased. Both the medical physician that you're with or yourself may be biased to try really hard to think what actually caused this disease. So all of these things actually make it very challenging to establish a diagnosis. So let's talk first about fibrotic lung diseases that are known to be due to exposures. I'll talk about the pneumoconioses and chronic hypersensitivity pneumonitis, namely. So pneumoconioses are chronic lung diseases that are caused by inhaling dust. And the most common pneumoconioses are asbestosis, silicosis, and coal workers' pneumoconiosis. So here's a classic case of a patient with asbestosis. This is a 78-year-old gentleman, a former smoker and pipe fitter, who presents with slowly progressive shortness of breath and a dry cough. And while I do have a CT scan here, going into details about the CT scan is certainly beyond what we have time for today. I just want to mention that the CAT scan can look very similar to something like you would see in an idiopathic pulmonary fibrosis patient, although very frequently you have something called a pleural plaque, which is highlighted there and pointed to with the red arrow. And a pleural plaque is, the pleura is the lining of the lung, and that can become scarred, and little calcium deposits can form in that scar, and that is very typical of patients who have asbestos exposure. The plaques themselves don't cause a problem, it's the fibrosis that actually would cause a problem. So what are the general questions that your doctor may ask you in the office as they're trying to figure out what caused your disease? What was your job title and company? And the part that's really time consuming about all this is that they need to know not only what your most recent job was, but all the jobs that you had, including at times, for example, military exposures. When and how long did you work there? What chemicals and materials did you work with? What products did your company make? And sometimes even very basic questions such as were you exposed to any dust, gases, vapors, and fumes can be very helpful. In addition to what products were made by your company or what kind of materials that you worked with, other questions include how dirty the environment was, how much exposure did you get, or were there any factors that actually made the exposure a little bit less? So typical questions are, was the environment very dusty or dirty? Could you see dust in the air? Did your clothes get dirty? And in fact, there have been reports of people bringing their clothes home and spouses who've washed the clothes, for example, getting diseases such as asbestosis. Did you wear a mask or any protective clothing? Was there a good ventilation system? And were any of your coworkers sick? And in addition to all of this, you'd also want to ask if there were any hobbies as well. Frequently, people are doing things that expose them, such as people who like doing woodworking, for example, may be exposed to a lot of dust. So Dave, I wanted to ask you, this is a very comprehensive list of questions. How are you able to actually approach this in your clinic during your visit?
Yeah, thanks. So obviously this is something you and I deal with extremely frequently. We do a couple of things. One is we have our new patients who are seeing us for the first time fill out a questionnaire. And as you well know, because you're leading national efforts in this area, there really is no single widely used questionnaire. So we've kind of developed our own. But then after that, I actually go again through it with the patient. That is, I don't rely solely on what someone has written down on our checklist and text areas. I go through it, and I, from an occupational perspective, I start with their current position. What do you do now, unless they're retired? And I work my way backwards, asking about particular exposures, going back all the way to when they were a young adult. And I ask about military experience and get details there. I don't think it takes me an extraordinary amount of time to do, but it is something I pay a lot of attention to. I do it with every single patient. I probably have some patients listening, they may recall. And but it's not like it doesn't take me 20 minutes to do. I've heard other doctors say they spend a very long time. And I'd really love to learn from them. I wonder how long you do this. I'd really like to learn from them what they do. Maybe I could learn some more.
Thank you. I think it certainly depends on the person, and as you'll see with the asbestos story too, one of the things that happens is certainly over the years there have been a lot of regulations that have happened, and so somebody who was working in 1970 in the same job may have a very different exposure from somebody who was working in 1995. And so there are all sorts of other factors, even in the same job position, that can make a difference. So I think it can definitely depend on the patient, and there are all sorts of other factors outside of asking the individual person, which could mitigate things or lessen some of the exposures. So talking briefly about asbestos, and asbestos is actually, there's a reason that it was very popular to use. It was a good product. It is a good product in the sense that it's used frequently in construction and manufacturing, or was at least. It's a naturally occurring mineral. It's very resistant to chemicals, heat, and electricity. It's soft and flexible, and it can be woven into chemicals. And there's 6 different types of asbestos, and the most common one is chrysotile, but all of them have been associated with lung disease. And these are examples of the historical asbestos use in the past, and you can see that it was used in a lot of insulation materials and ceilings and roof and shingles. And so many older buildings still may actually have asbestos. Now, generally, when asbestos is left and it's enclosed and not loose, it doesn't usually cause a problem, but it does cause a problem potentially to people who are working with it, who are not fully protected. So asbestos regulations began, at least in the United States, in the 1970s and continued on into the 80s. And the Occupational Safety and Health Administration, which is in the U.S. Department of Labor, really established some guidelines for the use of asbestos and rules around medical surveillance. So asbestos is actually not completely banned in the United States. However, its use is really significantly regulated. So there are limits to the amount of asbestos that can be used. There are requirements regarding protection and the type of equipment that needs to be used to protect yourself. And then there is mandatory surveillance or monitoring of workers to make sure that they're not developing disease. And what you can see here above is somebody who is adequately protected from asbestos. He has a respirator on that's enclosed, but in addition to that, you can see that his hands are covered, his body is covered. Some of the materials are disposable or can be washed, because remember, the fibers not only can be inhaled in, but can actually attach to your clothes. So really protecting yourself completely becomes important. And in the United States, there was a significant amount of asbestos use after World War II. And you can see here with the red arrow between 1950 and 1990, the black area represents the U.S. Consumption or use of asbestos. And you can see that there was really a significant decline in the amount of asbestos that was used. And along with this, you see that after peaking in the 1990s, 2000, the number of people who have died from asbestos have continued to decline. And again, you see that since asbestos develops about 20 years afterwards, you can see that this lags 15 to 20 years behind when asbestos started to be regulated. So who's at risk now? Generally, it's older workers who may have worked in these environments before there was a lot of regulation. There are workers who are managing the remaining hazard, particularly those who are not wearing the appropriate equipment. New products, and asbestos is still being used in low and middle income countries as well. So products from there would potentially contain asbestos. So asbestos, as I've mentioned a few times, the symptoms occur approximately 20 plus years after exposure. Shortness of breath and cough can develop slowly. On physical exam, your doctor might hear crackles and detect low oxygen levels. And there's no proven treatment, but there is the importance of supportive care. And in patients who develop severe disease, certainly lung transplant. So how does one make a diagnosis of asbestos? Well, really, history is most important. And testing can be performed and will usually be performed in the office with breathing studies and oxygen levels, particularly when you're walking. Usually your pulmonary function testing or breathing studies will show scarred lungs, which are restricted, and a low diffusion capacity. Chest x-rays and CAT scans will show fibrosis or scar and also show the pleural plaque frequently that I showed in the earlier slide. Lung biopsy can be done in certain cases, but most frequently is not needed. If your doctor is doing a lung biopsy looking for asbestos, they really do have to request specific stains to actually detect the fibers. The pathologist who's looking at the slides will not look at it alone. And above example, the black, what we call asbestos bodies are what we call iron stains, which coat the asbestos fiber, which is in the middle. So what are the lessons learned from asbestosis, which is a classic exposure-related fibrotic interstitial lung disease? There's a long time between exposure and first disease signs, no acute symptoms. Diagnosis alone with history is very important in a typical CAT scan, and usually lung biopsies are needed. And most important, and also very important, is that prevention actually works. And so particularly for diseases where often we don't have a treatment, prevention and regulation can really have a significant impact in really reducing exposure. So what about some of the other pneumoconioses? I'm going to talk mainly about co-workers pneumoconiosis and not really talk too much about silicosis, as co-workers pneumoconiosis has certainly been in the news. So co-workers pneumoconiosis is a chronic lung disease caused by coal dust over many years. And coal mine dust includes carbon particles and silica particles. And in fact, the silica particles, or the more silica content there is, may put somebody at more risk for developing the disease. Coal miners in their environments are often exposed to other things as well with the machinery, including gases, including diesel exhaust, which also may contribute to some of the exposures that they're inhaling. Underground miners, as opposed to surface miners, have higher exposures. Unfortunately, there's no treatment. And like asbestos, there are established regulations. In 1969, the Federal Coal Mine Health and Safety Act established regulations, medical monitoring, and a lung benefits program for those who develop disease. So these are examples of x-rays for patients who have co-workers pneumoconiosis. And just briefly talking about it, first of all, the pattern is very different from asbestos. There are 3 x-rays on this image. The image that is surrounded by a green square is a normal x-ray. The middle square, surrounded by a red, is what we call simple co-workers pneumoconiosis. And if you look at the lung fields, you can see that there are lots of little small nodules or spots in the lung, in the right and the left lung. And as disease progresses, or in patients who have a more severe form, they have the X-ray, which is encircled by the purple square, and that is a form called progressive massive fibrosis, and that's where all those little spots or nodules have combined together to form these things that are called masses. And as you can imagine, patients with progressive massive fibrosis have more symptoms. So you can see from this graph that after 1980, there really seemed to be a reduction in people applying for benefits with coal miners pneumoconiosis. It's also called black lung. And then somewhere around 2000, there seemed to be an increase in the number of cases. And so actually in 2014, there were more regulations pushed forward, and hopefully we'll begin to see a decrease. The other thing of note is that it is the more severe form of coal workers pneumoconiosis or progressive massive fibrosis which has been seen, which is particularly concerning. So let's move on to chronic hypersensitivity pneumonitis, which is also a form of fibrotic interstitial lung disease, which is due to exposure. So here's a classic case. Here's a patient who is 60 years old, a 60-year-old woman who presents with chronic, slowly progressive shortness of breath and a dry cough. And the CAT scan here, in many ways, has the scar that's quite typical of idiopathic pulmonary fibrosis, but there are a few features that are different. It's in the upper lung zone areas as opposed to the lower lung zones, and there are areas of what we call air trapping as well. Again, talking about CT scans are probably a little bit beyond this course, but wanted to highlight that there are some differences. So on further history, she reported that she had been working on a poultry farm for many years. She denied any symptoms related to work. So here's an example of chronic hypersensitivity pneumonitis. In this particular patient, we'd call it bird fancier's lung. Symptoms here occur after months to years of exposure. Very often, although occasionally it can occur, there are no acute symptoms that are reported during exposure. And chronic hypersensitivity pneumonitis is associated with scar in the lung. There are other forms of hypersensitivity pneumonitis which are reversible, but those are not chronic hypersensitivity pneumonitis where there's established scar. So in terms of treatment, scar is often permanent, unfortunately. Although if there are some areas of active inflammation, removing or eliminating the exposure can be very helpful, and we know that patients do better when we take away the exposure. And in other situations, certain medications such as steroids and other immunosuppressive drugs can also make a difference. And I want to note for both chronic hypersensitivity pneumonitis and the pneumoconiosis that some of the newer drugs for IPF that are out have not been proven to be effective in these patients. And so we do not typically prescribe these medications to the patients. So what are the causes? What are some causes of hypersensitivity pneumonitis? Well, looking at this slide, you'll see a theme. Generally, anywhere there's water and mold or bacteria can grow, there can be a reaction, a hypersensitivity pneumonitis reaction. And there's several environments here, both in the farms, patients who use hot tubs or humidifiers just from the standing water. Those can be contaminated with bacteria and fungus. People who work with metal working fluids, machinists in factories, the metal working fluids themselves, if not taken care of correctly, can also become contaminated with bacteria. In addition to bacteria and fungus, there are some chemicals that are associated with hypersensitivity pneumonitis, such as isocyanate, or chemical workers' lung, isocyanate hypersensitivity pneumonitis. And this is a chemical that's often used in paints and plastics and resins, and there have been outbreaks of patients with hypersensitivity pneumonitis reported there as well. So how does one make a diagnosis here? Again, history, and I keep coming back to this point with exposure, history is so critical because if you don't think about it or ask, you're never going to make the diagnosis. So breathing tests, pulmonary function tests, oxygen walk tests are typically performed. There are blood tests called serum precipitants that your doctor may perform to make a diagnosis. They check to see if your body has developed antibodies against the exposure. Unfortunately, these tests are not 100% perfect, and oftentimes even people who do not have lung disease will have these tests be positive, or people who have lung disease will have a test that's not negative. So they are not reliable tests. Chest CT scans are certainly performed, and then lung samples and biopsies can also be performed in certain cases. And I talked briefly about this CAT scan in a previous slide, talking about that there are certain features that differentiate or look different from patients with IPF. There is scar in patients with chronic hypersensitivity pneumonitis, but it's generally more in the upper and middle lung zones rather than the lower lobes, and there also may be evidence of inflammation in the airways or air trapping. And sometimes physicians will see that a CAT scan looks like hypersensitivity pneumonitis and then go back to the patient and take a better history about exposures. So there's been a lot of interest in trying to define how we look at and diagnose and treat hypersensitivity pneumonitis in the medical community. And so recently, there have been different strategies or algorithms that have been published suggesting how we might go about it. And in certain situations, your doctor may want to do, if there's a typical history or a CAT scan that's very suggestive, do what's called a bronchoscopy, which is an outpatient procedure where the physician will place a small tube in your airways and get samples. And taking some fluid from the lung and sending it to the lab may show an increase in a certain type of inflammatory cell or white blood cell. And if that's there, that can be suggestive of hypersensitivity pneumonitis. And we certainly think about this being less invasive than surgery. So I wanted to stop there, and Dave, I wanted to ask how you're approaching your patients with suspected hypersensitivity pneumonitis in your practice in terms of biopsies and bronchoscopies.
Sure. Yeah, there's certainly a lot of variation in practice, as you know, around the world in how these patients are diagnosed. I almost take the approach in my practice that all of the patients with fibrotic disease that I see have hypersensitivity pneumonitis until I prove that they don't. And that's really because in my practice, I see so many patients with this condition. And of course, it's something where if we can identify the trigger and the environment, we might be able to help the patient. So just like I do for occupational stuff, we have a questionnaire that we have people fill out. It's fairly brief. But then again, with the patient, I'll spend a lot of time asking about the ventilation system in their home, if they have one, if they've had water damage, mold, hot tubs, humidifiers, other things where mold could breed, or of course, exposure to birds. While we're talking, we do have a question from our listeners that I wanted to bring up, and it has to do with potential exposure to fumes from chemicals used to treat swimming pools, and whether that could be associated with pulmonary fibrosis. In my experience, those chemicals like chlorine can trigger asthma, but I'm not aware of any data that they're linked to pulmonary fibrosis. Are you?
Yeah, generally chlorine can trigger asthma. I mean, there have been outbreaks in spas, for example, of more acute hypersensitivity pneumonitis. And there's been some contamination with non-tuberculosis mycobacterium, which is a particular type of bacteria. But typically the chlorine is more associated with asthma. But again, there have been outbreaks.
Great, thanks.
So how often are you doing bronchoscopy and biopsies, and all your patients able to actually tolerate them?
Yeah, sorry, I didn't answer that right. So personally, I do not refer for bronchoscopy or do bronchoscopy when HP is on the differential. I've just found it not to be as helpful as I would like, because I think that it can be helpful in extreme cases with a lot of lymphocytosis. But I think when we've seen that, we've often seen very characteristic changes on CT. And when it's all fibrotic, I don't know that we always see that. On the other hand, I've also begun to shy away more and more from doing surgical biopsies, unless I really think that I need that information to inform how I'm going to treat the patient or recommend treatment to the patient. Just because, as you know, there is a little bit of risk with the biopsy, and at least surgical biopsy. So I've begun more and more trying to make diagnoses without doing any invasive procedures as best I can. Not that no one gets a biopsy. I certainly do send people for biopsies. But I try to make sure that the CAT scan is done the right way, and that we have all the right blood work and we have all the information from the patient. And I really try to avoid everything. But again, I don't routinely do bronchs. Do you?
I struggle with the same question as well, because if there are typical features and there's a typical exposure, then I don't know that it's going to make any difference. And often the patients with fibrosis are going to have trouble responding. I think it can be helpful if there are multiple things that are going on at the same time. But I'm also shying away from surgical biopsies now too, quite a bit, except in certain situations. We know there's risks of exacerbations and things like that as well. But I think, this sort of highlights needing to there's a lot of interest in trying to standardize an approach for physicians across, and there's so much variability, I think, in practice. So I'm really, thinking about how I'm incorporating bronchoscopies into the practice right now and what situations that they would be the most helpful to use. So, okay, thanks. So I'm going to keep going, and I'm going to turn to exposures and idiopathic pulmonary fibrosis. So going back to our ILD universe, idiopathic pulmonary fibrosis falls in the area under interstitial lung diseases of unknown or supposedly unknown cause. And this is a typical case of a patient with idiopathic pulmonary fibrosis, 65-year-old male former smoker who worked as a machinist who presents with slowly progressive shortness of breath and dry cough. Sounds very similar. Well, there are a couple of exposures in there, and do we actually think those are relevant? So many scientists in the community believe that IPF, that how does the process of IPF, how does IPF develop? Well, they believe that it starts with a lung injury. Well, what is that lung injury? For those of you who've been in the office, I assume frequently you're being asked about reflux. Well, reflux, for example, is kind of an internal exposure where it can come all the way up from your stomach, and the acid and not acid parts of the gastroesophageal reflux may itself go down into the lungs and cause lung injury. But what about just regular exposures, occupational environmental exposures, and other exposures such as bacteria or fungus? So what evidence could we rely on to help prove that exposures cause IPF? So when scientists try to prove causation, they look at many different sources of evidence. So for example, they look at animal studies or models. So if we it's easier to give test animals with exposures to dust and see if they develop something rather than exposing humans to do that. Secondly, it has to make sense. So it has to be what we call biologically plausible. And we don't just need animal studies to prove things. We also need human studies that support it. Would it be helpful to find the exposure in the lung tissue? I think that's a question, and certainly more complicated as Dave and I were just talking about how we're increasingly trying to shying away from doing lung biopsies just to minimize risk. And then are there any genetic differences? We know that some people are more vulnerable to lung injury than other people. Is that why some exposures may cause disease in some people and then, but not in others? So posing a question, which of the following exposures have been suggested to be associated with IPF? Smoking, wood dust, metal dust, or all of the above? Well, the truth is all of the above. And so there have been many what we call observational studies in several different countries, in Europe, in the United States. And most of the studies recruited patients from hospitals, and the exposure history was based on a questionnaire, somebody's self-report or questionnaire and interviews. So no objective going into the factory and actually measuring dust. And there was suggestion that all of these things that are listed above were associated with IPF. Again, let's remember the challenges. These were patients or individuals who were questioned many, many years after exposure, so they didn't have symptoms. So they really had to try to remember what they were exposed to. And they also may be more biased to find a past exposure because they're trying to explain to themselves why they actually developed disease. What about looking inside the lung tissue to see if we can find anything? There are really not more than a handful of studies that actually do this. This, for example, is one study out of Japan that looked at the lymph nodes in the chest. So lymph nodes are structures that hold that have immune cells and actually filter other things from the body. And it would make sense that any foreign material may be filtered through the lymph nodes in the chest if somebody's exposed, or that's the theory. And in this study, there were patients, 23 patients, where there was some evidence of silica and aluminum. And these tests are not standardly done in the lab. You really have to do specialized type of microscopy to actually detect this. And here's another case of a series of patients who had what I put here as a UIP pattern, but really pulmonary fibrosis. And these patients had actually worked with metal. And there were two metals that were found, tungsten for example, that were found in the lung tissue itself. Now, although the metal was actually found, there wasn't necessarily a lot of fibrosis or inflammation immediately around it. So the question is, here are a couple of examples. We found that there was some exposure. Just because we find exposure or some kind of material in the lung, is that enough to say that that actually causes disease? And I think that is a question that we struggle with as well. So what about air pollution? There's been a lot of data suggesting that air pollution does have effects on health in general, but what about idiopathic pulmonary fibrosis? And we've really only scratched the surface with this. And here's an example of one small study that looked at individuals and looked at their lung function over time. And that's what the forced vital capacity is. And they looked at measurements based on where they lived of PM10. And that essentially is air particles, and there are air quality standards that are published in the United States. And those who had higher levels of particulate matter seemed to have more of a decline in their lung function over time. So it's interesting. I think there is a lot more that needs to be done there. And actually, in this particular study, these were not very polluted areas either. But there is a suggestion, and there may be worth following this up. So key points summarizing everything. Exposure-related fibrotic interstitial lung diseases such as asbestosis and coal workers' pneumoconiosis and chronic hypersensitivity pneumonitis have certainly been reported. And I think this kind of raises the question, is idiopathic pulmonary fibrosis caused by an exposure as well? And we just haven't been able to find it. So thank you, and I'm certainly open for questions.
Wonderful, thank you, Mridu. That was really terrific. I think I certainly learned a little bit there myself. We do have a question, which is about susceptibility. That some people are more susceptible to, say, exposures or some trigger than others. Can you comment on what makes some people more susceptible than others?
There's been a lot of interest in looking at genetic risk factors. And in fact, there's one genetic risk factor which involves the airways and sort of the mucus in the airways that protects us from exposures. And it may be that some people are more susceptible to lung injury. I think there's a lot more that needs to happen and is certainly being looked at. There's a lot of interest in looking at what we call gene-environment interactions to really understand why some people may get a disease and other people don't.
Yeah, 100% agree. And then I would add that what we don't really understand, or at least we're beginning to understand, is that some of the cells in the lung undergo accelerated aging, which means that those cells are older than some of the other cells in the body. Even if not older by time, they act as if they're old cells, so they don't work as well. And if they don't work as well, and then some kind of exposure comes along, the lung will have difficulty healing itself. And there are some genes that seem to predispose to that problem. And we're learning more and more about what that means, how it influences people, and how it might even influence how they respond to different forms of treatment. So we have a couple more questions. One is about climate, and are different climates better or worse for people with IPF compared to other climates? I certainly get this question a lot. I'm interested in how you answer this question.
I think other than a little bit of the air pollution, that in terms of specific data, I'm not aware of specific data. I think very frequently we all hear that extremes of climate are very difficult for patients. I've heard it so many times in the office that I have to believe that that's true for so many patients. But certainly if you also have a coexisting, asthma or some kind of allergy thing, I think that could also make a difference. But I'm not aware of specific data just with climate itself. Dave, I don't know if you have anything else to add, but I certainly hear patients talk about it, and I believe them.
Oh yeah, my answer is no. I'm certainly not aware of any data. My experience with patients is that they certainly feel better in different climates. A lot of my patients want to travel south for the winter, and some say that they prefer dry weather, and others humid. And I can't find any rhyme or reason to it. It seems to vary by the person. And I think that's great that we're able to find climates that suit different people better and might help people feel better. But I don't think it's affecting the lungs directly, as far as I know. We do have another question, which is about pulmonary emboli, which are blood clots in the lungs, and whether there's any link between these blood clots and pulmonary fibrosis. And my answer is yes. We know that people with pulmonary fibrosis are at increased risk to develop blood clots in the lungs and maybe other organs. We don't understand why that is, and we don't think the blood clots are causing scarring. They can cause injury to the lung, but we don't think they're causing scarring. But still a lot to be discovered about how those two are linked. Anything to add to that?
No, and I don't think that there's any additional sort of exposure related to the blood clot information out there that is also relevant.
So this is about exposures in the military, which we were talking about before. This person was exposed to lubricants, fuel, chromium-laced paints, and lived in barracks that had asbestos. They're asking where I can get a list of possible chemicals. Maybe the first question is, what do you have any concerns about those exposures that you heard that I listed?
I think two things. I think, first of all, of the ones that you mentioned, certainly asbestos would be the one that I would think the most about with regards to any pulmonary fibrosis. If you are within the VA system, there certainly should be availability of information of whether or not there, depending on where you were, if there were other individuals, if there was any asbestos or any chemicals that there was concern about. Now, in terms of the asbestos exposure, generally the asbestos exposure would have to be loose, or it couldn't be exposure that's enclosed or buried. Generally doesn't cause any problems. So it would have to be asbestos exposure that you were exposed to, which was loose and that you had direct exposure to.
Yeah. And can you, on a related point, talk about material safety data sheets and what they are and how to obtain them?
Yes. Yeah, so thank you for bringing that up. So material safety data sheets. So your employer, whatever materials that you work with, by law, they have to actually supply information to you in the form of what are called material safety data sheets, which actually give you information about the different things that you work with, what they contain, and any kind of hazard or risks that have been associated with that particular exposure.
Yeah.
So thanks for asking me that.
Sure. So another question, and this is a really good one. Do you treat pulmonary fibrosis differently if you know the cause of the exposure?
The main thing, I think, when you find exposures, and depending on, and we also look at the pattern of the CAT scan and biopsies if they happen to be there. The most important thing really is to remove the exposure. Because we know that if we remove the exposure, for example, in chronic hypersensitivity pneumonitis, that patients will do better. Sometimes if it's an exposure-related lung disease, so certain times when there's chronic hypersensitivity pneumonitis and somebody's continuously being exposed, there may be areas that there is some inflammation, and so they may actually benefit from drugs that are immunosuppressive or anti-inflammatory. So those are the main ways that I treat. Generally just the unfortunately established scar without a lot of other things. There's not other than supportive care and treatments. We still need to have better treatments for the scar in those patients. So there's a lot more that we need to know.
Yeah, yeah.
Now, the other thing I would say is that all of these patients, there have been reports of acute exacerbations or flares of inflammatory flares that come out of the blue in these patients with a lot of the different forms of fibrotic lung disease. And so in those situations, I may treat them also aggressively.
Mm-hmm. Yeah. What about exposure to radiation, radiation therapy, or also this person asked about secondhand exposure to radiation through clothing of an exposed person?
So with radiation, I mean, certainly direct radiation has been, so individuals who go through radiation for cancer therapy, for example, they very often will have some evidence of scar in the lung. It often just remains a little bit of scar in the lung and doesn't necessarily progress. The other thing is that patients who have some who have IPF, for example, or pulmonary fibrosis, and then have to get radiation, sometimes you'll see in those patients that they may be more sensitive to having a reaction to radiation. So it kind of works both sides. I am not aware of any data on secondhand radiation in terms of causing lung disease.
Yeah, me neither. I've never heard of that. What about mold as a cause of IPF? We just got a question about that. Could that be possible?
So, there has been a lot of interest in mold, and so there have been certainly a lot of the areas that I talked about in chronic hypersensitivity, pneumonitis, some of the environments, it's the mold or the allergic reaction to the mold causing chronic hypersensitivity pneumonitis. And so this really gets to the question of, are we diagnosing IPF instead of chronic hypersensitivity pneumonitis? And so this gets to be very confusing. I mean, certainly there are features on CAT scans and biopsies that can suggest chronic hypersensitivity pneumonitis that would suggest that, and if there's an exposure to mold, I would be concerned. The other confusing thing about this is if there's a really, really strong history of mold, the truth is there are some patients that look like IPF even though they have chronic hypersensitivity pneumonitis. So, generally, so it does really have to be a lot of mold though. So a little bit of mold in your bathroom or a tiny amount, that amount of mold generally does not cause a problem. The amount of mold that causes a problem, there really has to be a lot of structural damage to a place or a lot of exposure. And the other thing I'll say about mold is that, unfortunately, there are no measurements. There's no measurements that say this much mold is too much. It's almost like if you ask some of your occupational medicine doctors, they'll say, you'll know it when you see it. But there's no specific tests that say this is too much mold, you've been exposed.
Right. And a related question that's come up is what's actually being looked at in the homes of people with hypersensitivity pneumonitis or lung disease?
Now, I mean, that's actually a really good question. So I think that, when somebody comes in, one of the most important parts is actually doing a walkthrough and actually looking at everything in the home. And that also means, taking carpets and looking under the carpets and looking under the beds as well, and really seeing, what's actually there, going to the basements. Sometimes if there's been, in areas where there have been a lot of floods, there will be a lot of structural damage to the house and you'll actually smell a lot. And so you may want to look a little bit further, but that visual inspection is actually probably one of the most important things in the history of any damage to the building. There are samples that people can take, and this is where it gets a little bit tricky. Some people believe that there are certain molds that are more toxic than others. There is also the suggestion that if you have higher levels of mold is everywhere. So if you have higher levels of mold inside than outside, that might be a problem. But I'm very careful with putting too much weight on a lot of the sampling that actually happens in any specific numbers.
Yeah.
So, and when somebody comes in, they may make some recommendations. They'll also look at the ventilation system. Frequently, for example, schools are kind of a problem, making sure that the ventilation system has been cleaned and updated as well, and you have enough fresh air that's coming in.
Yeah, I also struggle. There's a lot of variation in how mold is measured in the home when it's done. And hopefully someday we get that standardized and figure out what is a meaningful amount of mold. Going back to military exposures, a question about whether or not pulmonary fibrosis is more common in veterans.
So, it's a question I think we've been thinking about too, is particularly with recent things that have been happening. I mean, there's certainly groups of people that are actually being followed now. I mean, I think in terms of where there have been reports of certain types of lung disease, not necessarily always pulmonary fibrosis, but there certainly has been concern. I think prior historical concerns, I think for a lot of individuals who were in the Navy, for example, or shipyards, there was concern for asbestos exposure in particular.
Yeah. Sorry to jump around and throw all these questions at you, but they're really great questions. And I think you kind of answered the first part of this question, and we haven't addressed the second part. So the first part has to do with, if I was a teacher in a school building with asbestos, could that cause pulmonary fibrosis? And you had said, and this is what I tell my patients too, is that asbestos that is undisturbed is not a problem. It's when it is particulate, or when it becomes dust and it's disturbed and airborne, that it can become a problem. Does that match your thoughts on this?
Yes. Yes.
Yeah. And then the second part has to do with radon, which is also a question I get in my office. We all know that radon is a risk factor for lung cancer. And radon, if you don't know, is a gas that's naturally occurring in the earth. And as it rises out of the earth, it can accumulate in people's homes, particularly in the basement. And there are ways to test for it, and there are ways to get rid of it and deal with the problem. I was not aware of any data, and I found one small study, or not small study, but one study maybe a decade ago that, among many other things, suggested that maybe radon and all these other things might cause scarring. But I would say that's not definitive, and I'm not really aware of any data that strongly supports radon as a cause of pulmonary fibrosis. Are you?
No, I'm not. I'm not either. I don't typically consider it a risk factor for pulmonary fibrosis.
Yeah. Here's a question about thyroid treatment and lung issues, and I will mention, and then Mridu, you can mention this, because I know Naftali Kaminsky at Yale has done some work on this, that there does seem to be some link between thyroid and fibrosis in the lungs, and I think it's not completely sorted out. Do you want to talk about Naftali Kaminsky's work, or?
Yeah, I think everything's kind of, we're very hopeful. I think everything's kind of investigational at this point. So I don't know that, it's raised to the level of, being able to talk about it in detail at this point. So, and if you want to add anything else.
No, I think there's intriguing research linking thyroid conditions and fibrosis, but I think we need to see more information and really understand what it's all about. We have
and just to clarify, Dr. Kaminsky is an internationally world-renowned leader at Yale who is very involved in research and involved in a lot of scientific investigation, genetic investigation, biomarkers, et cetera. So, we're excited about his work.
Yeah. I'm going to try to summarize a couple of other questions into one question, which is about treatment and whether drugs like pirfenidone or nintedanib or N-acetylcysteine, and just so everyone knows, N-acetylcysteine also goes by the name NAC, N-A-C, NAC, whether any of these are used or effective to treat hypersensitivity pneumonitis.
At this point, the FDA has not approved the use of those drugs for patients who don't have IPF. There are clinical trials that are ongoing that are looking to see if these drugs actually make a difference. And I think that, you know, it is definitely a huge unmet need for all the patients that have pulmonary fibrosis who don't have IPF and who also need treatment. I think that's a really huge area, and I think that companies are now and academia is really now coming to terms with the fact that, you know, we're now developing studies for those patients as well, but typically those drugs are not prescribed.
Yeah, I agree. So I think we're out of time. I'm going to ask all of those people who sent us these wonderful questions. You can email us. The email is PCC, like Peter Charles, PCC at pulmonaryfibrosis.org. You can also find that email on our website, which is pulmonaryfibrosis.org. So please go ahead and send them. We'll do our best to respond and give you the best information we can. I do want to let you know that we will be holding another webinar in February, in just 2 weeks, on February 13th. And it is entitled Pulmonary Fibrosis and Mental Health, a Roadmap for Coping. And this will be presented by Dr. Deborah Gilman, who's a psychologist at the University of Pittsburgh in the Interstitial Lung Disease program there. So look for emails about that. We hope you sign up and register. And Dr. Gulati, I want to thank you again. This was fantastic. As you can see, a lot of interest based on all these questions. I also want to thank Lindsay Bassett from PFF, who's there in the background, coordinating all of this and doing a fantastic job, and our sponsors, Boehringer Ingelheim and Genentech. So thanks, everyone, and I hope you'll log in 2 weeks from now for our next webinar. Bye-bye.